Welcome to the Epidemiology Seminar Series. I'm Angela Lee Wynn, Assistant Professor in the Department of Epidemiology at Colorado School of Public Health. Today we have Dr. Sara Yeatman as our speaker. We're truly excited to have her give us her talk on the impact of expanded contraceptive access on high school graduation in Colorado. Dr. Yeatman is Associate Professor and Chair in the Department of Health and Behavioral Sciences at CU Denver. She is trained as a social demographer with a PhD in sociology from University of Texas, Austin. Her research focuses on the social causes and consequences of fertility and HIV over time. Her current research examines how access to contraception and unintended fertility impact women's lives over time, both in the US and in Malawi. Today's seminar will be recorded and posted. Please put your questions in the chat box and we'll monitor them and have a Q&A session after Dr. Yeatman's presentation. So please welcome Dr. Yeatman.
Thank you, Angela, and thank you for Cassandra for organizing. I'm really pleased to be here. Like all of us, I wish that we could meet up in person these days, but hopefully that we'll be back to that in the near future, while still also benefiting from some of the advantages of Zoom talks, where people can join in from all over, which is also wonderful. As Angela mentioned, I am in the Department of Health and Behavioral Sciences at CU Denver. So as many of you probably know, we run the undergraduate major in public health with collaboration from the Colorado School of Public Health. And many co-instructors come from the Department of Epidemiology, and we're so grateful for that, as I know our students are as well. Most of my research, kind of for the last 15 years, I've been conducting work in Malawi in Southeastern Africa, where I ran a panel study of about 3,000 young men and women, following them over a period of 10 years. And just still sort of analyzing some of those data, but increasingly, as this talk suggests, I've started to turn to more of a domestic research agenda and examining some of the same sort of broad themes, but looking at them in a very different context here in the United States, and in the talk I'm going to present today, specifically within the context of Colorado. So this work is very much a collaboration. So these are the principal collaborators of mine on this project, which we've been working together for the last few years. Amanda Stevenson is the principal investigator on this project. She's an assistant professor in the Department of Sociology. Katie Genetic over on the left is with the Census Bureau, and she's an economist. So this is a nice interdisciplinary project. Jane Mencken is emeritus professor in sociology at Boulder, and Steph Milburn is a professor of sociology at Boulder. And then Joshua Sanders is our mathematician and data guru. The project I'm presenting on, when I initially committed to giving this talk, I imagined I would be presenting on the sort of follow-up of this project, but things always go a little bit slower than you anticipate. So I am leading the follow-up project. So this one, as the title suggests, focuses on high school graduation, and I'm leading the project that looks at the next step, and it looks at college graduation. And I'm happy to talk about that a little bit in general at the end in the Q&A. But essentially, all of our work is taking place within the Rocky Mountain Research Data Center, which is a wonderful resource I'd be happy to share more details on. But we are using census data and American Community Survey data in this cold room in Boulder. And everything has to come out through Census Bureau disclosure. And so everything just takes longer than you think it will, which is why I'm presenting on our earlier project. We've had a number of funders for the data development stage of this work, and now we are mostly funded by the William and Flora Hewlett Foundation and the National Institute of Child Health and Human Development, NICHD. Sorry, just trying to make sure I can see all my notes. In her dissent in Gonzalez versus Carhart, Justice Ruth Bader Ginsburg wrote that women's, quote, ability to realize their full potential is intimately connected to their ability to control their reproductive lives. While arguments for access to contraception are based on a number of principles, including justice, human rights, women's health, child's health, justifications for publicly funded family planning in the United States often rest on a narrow and testable version of Ginsburg's claim that access to contraception has beneficial effects for women's lives that reach beyond fertility outcomes to their education, employment, risk of poverty, etc. And before I present our particular study, it's important that I convince you of two things. One, there's little contemporary evidence in support of Ginsburg's claim. And two, this is something we should all care about. This really matters because the public funding of contraception in the United States is increasingly contested. The only dedicated family planning funding stream in the US is the Title X program, which funds access to sexual and reproductive health services for low-income and uninsured residents. Title X began in 1970 at the request of Richard Nixon, and while it has long been underfunded, covering only about a third of estimated need, maintaining fundings at these low levels was relatively depoliticized and bipartisan. That is until the early part of last decade, when in 2011, restrictions in Texas, and then later in 2018, 2019, national restrictions imposed by the Trump administration have curbed Title X and threatened its survival. These restrictions include excluding providers who refer clients for abortion care, which was since reversed by President Biden on January 28th, but also importantly, the Trump administration changed a little discussed rule in the Title X grantee guidelines, making it possible for grantees to offer only one method of contraception, even if that method is abstinence-based fertility awareness training. Previously, the program had required grantees to offer a wide variety of FDA-approved methods, and many states had further required that all awardees provide one of each type of FDA-approved method, so at least one IUD, at least one type of oral contraceptive pill. But in 2019, that requirement was dropped. These debates over and changes in Title X are taking place against a backdrop of pretty poor access to contraception in Title X clinics. We know that because of rationing due to the block grant nature of the program, Title X patients experience unmet demand for contraception, particularly for the most expensive and effective methods like IUDs and implants. Because clinics which refer for or provide abortion services could, for a period, no longer receive Title X funding, many state legislatures have begun providing replacement state funds to keep funding flowing to these clinics. The national debate and these debates in the states make rationales for the public subsidy of contraception newly important in the United States. As I mentioned previously, however, these rationales rely heavily on the idea that access to contraception improves women's lives. However, the evidence in support of this claim is surprisingly weak. So here's a little conceptual diagram of the relationships we're focused on. Arrow 1 is the relationship of interest. Does access to the means of controlling fertility, does giving women access over their reproduction, does that lead to positive socioeconomic gains? But because there is little rigorous contemporary evidence to support it, arguments for Title X have rested on pulling together two bodies of literature represented here by arrows 2 and 3. Studies focused on arrow 2, for example, are things that might evaluate the impact of family planning programs such as Title X or more local programs on contraceptive use and birth rates. From these, it is clear that family planning programs increase contraceptive use and impact fertility, lowering teen fertility, for example. Arrow 2 studies include research examining the impact of teen fertility on life outcomes or evidence for a motherhood penalty in the labor force. However, we need to be cautious in pulling together these two bodies of literature to draw bigger conclusions. That family planning increased does not necessarily mean that women's outcomes did too. Even though teen births are associated with lower levels of high school completion, it does not mean that teen births caused that outcome. Indeed, decades of research has made clear that women who have teen births and subsequently do not graduate high school are disproportionately subject to social and economic disadvantage before they have children. So their non-graduation may not have been caused by their childbearing. All right, returning to arrow 1, there's some historical evidence to support a relationship. For example, studies have clearly demonstrated that the availability of the oral contraceptive pill in the 1960s when it was first introduced And the legalization of abortion following Roe versus Wade in the 1970s improved women's educational and employment outcomes. But these explanations are sort of 50 years, are from changes from 50 years ago. And the question of the effect of introducing contraception where no modern methods had previously been available, as in those cases, is not quite analogous to the question of whether changes in existing modern family planning programs impact women's lives. And this is the question our project seeks to address. Specifically, we ask in this particular analysis, does access to the full range of contraceptive methods increase young women's high school graduation? Finishing high school is associated with a range of favorable later life outcomes: better employment, better health, longer life expectancy. Indeed, here the work of my colleague, Patrick Kruger, has shown that the annual number of deaths attributed to not having a high school diploma in the US is larger than the number of deaths attributed to cigarette smoking. Finishing high school matters in our society. And so asking this arrow 1 question not only avoids the selection involved in these other arrows that I've described, but it also allows for an indirect effect that might not work through fertility. That is, could access itself impact women's human capital formation? Potential pathways here include, perhaps increased confidence that investment in education, either from the individual or from a family's perspective, that investing in the education of a young woman is going to yield benefits, and not just sort of, if she becomes pregnant as an adolescent and then has to drop out. So you might not invest in the first place, or just that concern that could happen. Additionally, there might be mental health improvements associated with the ability to control one's fertility that could influence education. To do this, and to answer arrow 1 questions in general, you need 2 things that have been in short supply. 1, you need an abrupt and large contraceptive intervention. And 2, you need longitudinal data that allow you to follow women from exposure to through to early adulthood. We have both. So I mentioned a little bit how Title X works in general, but I wanted to touch on one element and make sure that we drove this point home. Even though many Title X clinics might have IUDs or implants, so let's just think in Colorado before the Colorado Family Planning Initiative, which is what we focus on. Most Title X clinics had IUDs or implants available in theory, but in practice, because those methods were so expensive, even though they're cost effective over the long term, the way the funding for Title X works is that the clinics wouldn't have them on hand because they were so expensive in terms of upfront costs. So they might have really, really long wait lists for people who wanted to access these more effective methods. What the Colorado Family Planning Initiative did, it was a collaboration between a large anonymous foundation that worked through CDPHE and funded Title X clinics fully. So we tend to think of the Colorado Family Planning Initiative, which began in late 2009 and really went in its most intensive phase through 2014, and then it was taken over by local donors, and then ultimately has been picked up by the state government, but at a much lower level, a much lower funding level. We tend to think of CFPI as a LARC intervention. And so LARC stands for long-acting reversible contraceptives, such as IUDs and implants. But it was really more than that. And so it provided funding for these methods so they could be on hand and they could be available at every Title X clinic. It also provided training so that providers knew how to insert them and knew how to remove them as well. Logistical support for Title X clinics, and also advertising to ensure that all Title X family planning clients could choose any FDA-approved method of contraception. Essentially answering the question, what happens when you fully fund Title X, right? Which is what we're going to look at. Other researchers have documented a number of effects. So we saw dramatic increases in IUDs, in implants, and in sterilizations provided by Title X clinics in Colorado. We also saw marked declines in births and abortions in teens and young adults, including a 50% reduction in the teen birth rate, which is obviously very important for our question about high school graduation. I think it's also important to talk about who is predominantly served by Title X clinics in the state. In 2014, more than half of Title X clients were under age 25. 3/4 were below the federal poverty line, and almost half were Hispanic. All right, for our analysis, we use an econometric approach. We use difference in differences design, essentially examining changes in high school graduation in Colorado, comparing women who were too old and women who were just young enough to have their graduation impacted by CFPI. We then difference out changes from other states with similar education trends, but more on that in a few slides. Here, what I'm showing you is a demographer's favorite tool. This is a Lexus diagram. We have years on the x-axis and age on the y-axis. Our pre-cohort, pre-intervention cohort, so people who would have been too old to have their high school graduation impacted by CFPI, is in blue, and you can essentially follow them through their lives. These women were born in between 1989 and 1991 inclusive, and were ages 18 to 20 when CFPI came in. The post cohort or treatment cohort is in orange. They were born between 1994 and 1996 inclusive, and thus were ages 13 to 15 when CFPI came in. We think about the key period of exposure for when a family planning intervention might reasonably impact high school success to be sort of 15 to 17, that light purple horizontal chunk of time or age group. And so that post cohort, that treatment cohort, are exposed to peak CFPI during this key period. We observe our outcome, which is high school graduation. And here we separate out, we don't consider GED to be the same as high school graduation, although in sensitivity analyses we explore, we include GED, that it doesn't make a difference. And we capture this outcome in American Community Surveys, which is a very large survey, individual level survey conducted by the Census Bureau. It's both representative at the national level, but importantly, it has a large enough sample that it's representative at the state level as well. And so we measure this at ages 20 to 22, after the period where we think nobody is sort of graduating. Very few people are graduating high school. They might get their GED, but they're not graduating high school after sort of ages 20 to 22. The darker shapes within each of those cohorts, those little parallelograms that are darker in that observation period, those are the ages and years in which we measure high school graduation using these ACS data. You may note that the red parallelogram gets cut off a little bit because we don't have those later ACS years. So we age standardize our analytic cohort to account for that. And then additionally, here we use the 2010 census. So we're combining the ACS and the census, and we use the census as a measure of geographic location on April 1st, 2010. I'll explain that right now. So here are all the years we have from the American Community Survey, and using personal identification keys from the Census Bureau, we can link people to their 2010 census. So what the 2010 census gives us is residents in April 2010, and then we observe high school graduation in the ACS. Essentially, this is important because we don't care where they live in the ACS. And I think an example can be illustrative here. Imagine a 16-year-old in Colorado in 2010, exposed to CFPI. If we observe her 4 years later in the ACS in 2014, she may be in Colorado, or she may be somewhere like Arizona, and that movement could be connected with her education. Most policy analyses take an ecological approach and have to assume that individuals were indeed exposed to whatever program they're interested in. Our data allow us to place young women in Colorado or elsewhere in 2010, and then follow them through ages 20 to 22. As you can see here in this green box, this is an important step. A full 18% of those exposed to CFPI in Colorado in 2010 were out of the state when we picked them up in the ACS, and thus at risk of being miscategorized in terms of exposure to the program. And I don't show here, but also 14% of respondents who were in Colorado at their ACS response were not in Colorado at the 2010 census. And so I like to think of these as like Boulder students. So you can imagine students at CU Boulder, we wouldn't want to, if they came from out of state, but happened to complete an ACS while at Boulder, we wouldn't want to assume that they were exposed to CFPI. They were exposed to whatever regime was happening in the state in which they graduated from high school, which might not necessarily be Colorado. There is, however, a limitation to this approach that's worth noting, that linkages between the ACS and the census are pretty good, but they're not perfect. So using these picks, we match, the Census Bureau has an algorithm to sort of generate based on a variety of different things. But we match about 72% of women in the ACS to their 2010 census. Unsurprisingly, the other 28% are not missing at random. So we weight the data to account for differentials in linkage, in addition to using ACS weights and age standardizing our data. Then we create treatment and comparison groups based on state of residence in 2010. So we have a group who were in Colorado, and then parallel trends, which I'll discuss in a moment, and then a separate sensitivity analysis. We have another comparison group, which is just all the rest of the United States. So these are our parallel trend states. So there's 17 states. And our approach hinges on differencing out changes in high school graduation that were due to CFPI from general trends that preceded CFPI. So in order to do that, we identify a set of parallel trend states. So these are states that are not statistically significantly different in slope or intercept from Colorado and high school graduation for 20 to 22-year-olds in what we call the pre-period, which for identifying parallel trends is 2008 to 2013, because at ages 20 to 22, those individuals couldn't have been impacted by CFPI. Their high school graduation couldn't have been impacted by CFPI. Because other policies were changing at the same time, and principally the expansion of Medicaid, which is important, we also restrict our parallel trend states to states that also expanded Medicaid like Colorado did. I haven't talked about it yet, but we do run our analyses separately for, so we run them for all women, we run them for non-Hispanic white women, and we run them for Hispanic women in Colorado. And so we make sure that our parallel trend states were parallel for all of those subgroups, and that leads to this group of 17 states. Here are our sample sizes. You might note the very nice round numbers. That was not just good luck. That is because of disclosure rules. So all of our analyses come out through the Census Bureau disclosure process, and that involves rounding at these, rounding all of our findings or all of our data. So for Colorado, we have about 2,900 women in this control cohort, also in the ACS, and 2,200 in the treatment. The treatment numbers are a little bit lower. Those sort of post years are a little bit lower because of this age truncation here that I discussed and that we address by age standardizing. All right. So most studies examining the benefits of access to contraception on women's lives do not identify how the impacts of policies vary by race and ethnicity. And we think this is important. The inability to disaggregate effects by race and ethnicity leaves programs open to critiques that they are racist and antinatalist, just trying to stop the fertility of racial and ethnic minority populations, which is obviously something we should all be very concerned about. And so it was important for us in planning the study to try and examine whether the non-fertility benefits of something like CFPI would accrue evenly across different racial and ethnic groups. But as you all know, living in Colorado is not a particularly diverse state. And so because of sample size concerns, we are only able to disaggregate our findings for white non-Hispanic women and Hispanic women. Here are descriptive, just descriptive data over time, showing changes in high school graduation for 20 to 22-year-olds by state from 2008 through 2017. And so here you see that, so Colorado is in orange, and you can see a sort of uptick after 2013. States in black are the parallel trend states, and states in gray are the parts of the rest of the United States that were not part of the parallel trend states. Here's the equation for our difference and differences models that we run. We have an indicator of high school graduation at ACS response, an indicator of residence in Colorado at Census 2010, an indicator of being part of the post-intervention cohort, and then our DID estimate is that interaction between being in Colorado and being in that post cohort, and we include state fixed effects. So I have these in visual, in a figure as well in the next slide, but for those who want to see the nitty gritty numbers, here they are. So here in this pre-CFPI cohort, what this is telling us is that in this pre-period before CFPI, 88.2% of 20 to 22-year-olds in Colorado had graduated high school. So that's a pretty high number. It's substantially lower for Hispanic women in Colorado. And then when we look over time, we see an increase, and this is the percentage point difference, the increase. And then in parallel trend states, here are those also were changing, even though they weren't exposed to CFPI. So we want to take that into consideration, which gives us these difference and difference estimates. All right, so here it's the same results that you saw in the previous slide. These are showing you the percentage of women in Colorado, ages 20 to 22, who graduated high school, comparing the pre and post cohorts. The orange chunk reflects changes due to CFPI, whereas the gray reminds us not to attribute all of the change to CFPI, that there were other things contributing to increased high school graduation nationally or among parallel trend states, let's say, over this period. So what we see is a 1.7, or what we estimate is a 1.7 percentage point increase in high school graduation due to CFPI. We estimate that is 2.2 percentage points for non-Hispanic white women and 4.3 percentage points for Hispanic women. But importantly, and we sort of came to this a little bit late in our analysis, but in thinking about high school graduation, wondering whether, and particularly the differences and impacts between non-Hispanic white women and white women, whether looking at differences in the increase in high school graduation was the way we should be looking at it, or whether we should be thinking about the percentage without a high school diploma, and what would it take to get to full high school graduation. And so when we sort of flip things around, what there is in the control period, there's more room for improvement, let's say, among Hispanic women. There we actually see the decline. So overall, we see a 14 percentage point decline in kind of reaching full graduation, a 27.9% decline due to CFPI among non-Hispanic white women, and a 21.8% decline due to CFPI for Hispanic women. These analyses are complex. There are lots of decisions and assumptions that we make along the way. And so those are things that we wanted to check and test as we were proceeding. So we've conducted a smattering of robustness and sensitivity analyses. We ran everything as linear regressions initially, but because we have binary outcome, we reran everything with logistic, probit, link functions. None of the findings changed. We include models with fixed effects for age and year and no changes. We play around with how we should consider the GED. Is it should it count as high school graduation, or is it something different, something distinct? There's evidence from the sociological literature that a GED doesn't quite have some of the later life benefits in terms of health and employment as high school graduation. So for that reason, we decided to keep it separate, but we wanted to make sure our results weren't sensitive to different categorizations of the GED. And so we ran that a variety of different ways, and our findings are robust to that. Even though we think migration is really important and the use of the census and following women through the ACS is really important, we also are aware that it comes with limitations, particularly as has to do with the linkages in some women that we miss, that we have to drop from our sample. So we ran things different ways using just the ACS data. We considered whether Colorado birthplace was exposure rather than being in Colorado in 2010, and the findings were the same. We also did what sort of most policy analyses do and just assumed that contemporaneous exposure was what mattered. So where are you at the ACS when we pick you up at ages 20 to 22? That also didn't change our findings. Doing various things with the linkages as well. Our findings are robust if the comparison group are these parallel trend states, or if we compare to adjacent states, so states right around Colorado, or if we compare them to the rest of the United States, so all states besides Colorado, our findings are robust. We still see a roughly similar level increase in high school graduation. We also tried to slice things a little bit differently and look just at, because Colorado's graduation levels were a little bit lower than some of the parallel trend states, we just sort of looked at states that had high growth potential. So, it's easier to get a percentage point of change if your graduation level, if your base level is a little bit lower than if your base level is at 95%, then it's hard to get that additional single percentage point increase. But our findings were robust to that. We also, in response to reviewers, since this paper is under review, we ran everything with synthetic control methods, which we ultimately didn't prefer, but our findings again held. Playing around with weights, just using the ACS weights, not waiting for age or linkage, models with ACS weights and linkage only, not weighted for age structure, findings held. Also a falsification cohort. So if we moved everything 3 years over, is it just something about our research design? Is it something about our design that is leading to this finding? But when we use that same design, but over a different period where we wouldn't expect CFPI to have had an impact, it was pre-CFPI, we don't see this change that we're picking up here that we attribute to CFPI. All right. In conclusion, funding for Title X has consistently fallen well below the level required to provide care to all who are in need. CFPI fully funded Colorado's Title X program with the goal of facilitating access to the full range of contraceptive methods for all clients. Our analysis demonstrates that this expansion of services intervention, designed to ensure that every Title X client could freely choose from all FDA-approved methods of contraception with minimal barriers to initiation, significantly increased statewide high school graduation among young women. We find a statistically significant population-level increase of 1.7 percentage points in high school graduation due to improved access to the full range of contraceptive methods in Title X. From this, we estimate that CFPI resulted in an additional 3,800 Colorado women born between 1994 and 1996 graduating high school. We find a larger increase in high school graduation attributable to CFPI for Hispanic women than for non-Hispanic white women, but CFPI caused a greater percentage of non-Hispanic white women to graduate who might not have done so than it did for Hispanic women. Our future work, so this is an ongoing project. The first few years were really focused on the data structure, setting up the data, linking the data, figuring out how we would capture that impact of CFPI. And so we're going to build on this in lots of different ways. So I'm right now working on knee-deep in examining whether this finding that we identified here extends to college graduation and examining the impact for women as well as for men. So while we might not expect to see as large of an impact for men, we did want to explore that because it's possible that through changes in reproductive access for men's partners, that men might also benefit, might be able to defer going to the workforce, for example, and invest in education rather than if women are better able to control their reproduction. We are also linking census data with tax data, so which is very complex, to examine whether whether CFPI led to a reduction in kind of women dipping into poverty over time in sort of young adulthood, and looking at work and income as well. We're also starting to look at some of the mechanisms. So a lot of the early research on CFPI, right, that I shared a little bit of, is focused on teen fertility and young adult fertility, a lot of which we can assume is unwanted. But when we look at the way in which CFPI might have affected older women, the changes in fertility might look really different. And so we're trying to see if we can pick up some of that, and looking at things like parity progression. So are women less likely to go from 2 to 3 children than maybe they were previously? Age-specific cumulative fertility, which gets a little bit at the pace of fertility, of women's fertility, as well as birth intervals. So is there greater spacing and birth intervals? And finally, looking at distance to clinic models. So do women who lived close to clinics, do they benefit more from CFPI, or women who live further away from clinics? I'm not sure that's going to yield it's not going to be as fruitful, but I think it's something that's important to look at, particularly in thinking about impacts for rural Coloradans. Great, thank you very much. I look forward to your questions.
Thank you so much, Dr. Yeatman. We have one question. Jean, if you're still here, please, you can unmute and then ask the question yourself.
Yes. Hi, Dr. Yeatman, thank you. What a wonderful talk. And I also really liked the idea of including men and benefits for men, given they have such a strong role in what policies get passed. Anyway, my question was, given that Colorado is not as diverse as many other states, if you could do a similar study in another state, and I know the CFPI was particular to Colorado, where would you do it? What would be your kind of ideal, if you could?
Ooh. It's tricky. So there's a couple of things there, I think. One, there have been some follow-up, some additional large contraceptive interventions. So Delcan in Delaware comes to mind, but they often are in small states. It's obviously easier to have a big family planning intervention there, particularly when they're funded by an external donor. But looking at a really diverse state like Colorado or Florida, but they haven't had the same sorts of interventions. So I think that's tricky. You need the diverse setting intersected with the intensive intervention. So Iowa also had a smaller version of CFPI, but not necessarily more diverse than Colorado.
We have another question from Isaac. Isaac, would you like to unmute and then ask the question?
Sure. Thank you for this great talk. I was wondering I guess more than clinics, what kind of healthcare facilities were you thinking about evaluating on that last point on your future work? Is it participants in specific programs, FQHCs? Just kind of curious about that.
Yeah, we were keeping this focused on CFPI, which worked purely through Title X. So just looking at those clinics, because as you can imagine, if you think about, I don't have this picture in slides, but right now, but if you imagine where Title X clinics are in Colorado, right, like so many services and like population density in Colorado, it's all up and down that Front Range. And then in rural areas, there's a lot more, just greater distance to clinics. And so looking at, I think here sample size becomes a slight concern, maybe a serious concern, depending on which data we're using. But in rural areas, some people were a lot closer to a Title 10 clinic. And so then that really could dramatically change their access to things like IUDs and implants. Whereas if you lived in a similar rural area that didn't have a Title 10 clinic, you wouldn't have had access to those services. So I think that could give us just additional confidence that it was this change that has led to some of the outcomes that we've seen. And so for some of our analyses, when we're working with the American Community Survey, because it was a probability sample, our sample size, as large as it is at the Colorado level, once we start to slice it, and we saw this with racial and ethnic groups, that we don't have a large enough sample size. But for other analyses, when we're using the census data, we have the complete census. And if we're combining that with tax records, all of a sudden we have a much larger sample size that will allow us to do some new things. But then it doesn't have some of the outcomes that we're most interested in. So there's just trade-offs.
That's all the questions from the chat, but we invite you to unmute and ask any questions you may have.
Hi, this is Nicole Richmond. Can you guys hear me? Okay.
Yes, Nicole.
Hi. So I might have missed this, but I think from what I understand, you were able to directly link the individuals back to the ACS. So you had, I guess, okay, my question is, having worked for Boulder County Public Health and Positive Youth Development, I learned that, sorry about my dog, that the transgender needs, Colorado is kind of like a hub for transgender community, and what an adorable cat. And so my question is, because the census tract, especially under the last administration, was really not inclusive and used SOGI, sexual orientation, gender identity questions. I'm curious to the extent that if we look at it among women, right?
Mm-hmm.
And maybe it's not that big of a dilution of effect, but that when, if I'm transgender male, I would then, respond to male on my ACS.
Mm-hmm.
And so, but biologically, I can have children.
Sure.
Right. And so I'm just wondering, maybe that's a sensitivity analysis or something to look at. But otherwise, I think this is fabulous, and you have moved the dial tremendously for further funding. Title 10 is desperately needed.
Right. Thank you. You're right. That's something that I'm embarrassed we haven't really spent much time thinking about it, right? You have the data you have, but I think that's a really important consideration. We know that risks of unintended pregnancy are high among transgender men, and so thank you.
Greg, do you want to ask the question about the census quality?
I was just saying, in general, are demographers happy with the results of the 2020 census?
Ooh, 2020 census. Oh. I think there's a lot we don't know yet. I think things in some ways are better than we feared they would be, but that doesn't mean they're good. I think there's going to be a big asterisk on the 2020 census, and just the extent of just how big of a problem it will be moving forward is something that we should all keep a close eye on. Obviously, it's used for all manner of things, including redistricting, that we should all watch closely. I certainly don't know enough yet, but I don't think folks at the Census Bureau, including my collaborator, Kate Genetic, would have a confident answer just yet.
Thanks.
And, all that 2020, for so many reasons, we'll have a really big asterisk on it, but it's not, back in 1920, following the 1918 Spanish flu, and for a variety of reasons, that one was also a challenge. So, people who focus on the census are pretty good at trying to, at least for research purposes, trying to figure out ways that we can continue to use them over time and make up for some of the limitations. So hopefully that will be the case with 2020.
We have a little more than 10 minutes left in our allotted time. Dr. Yeatman, do you have any extra slides that you prepared, or any slides that you want to go back and expand a little more before we wrap up?
No, I mean, if anybody is interested in seeing just against the rest of the United States, we can see that the effect size is 1.33 there, which is a little bit lower, but still statistically significant, and I think broadly consistent. But that's about all. Sorry, I struggle to judge time sometimes, I think, on Zoom. I do the opposite when I teach. So I teach a 3-hour class right after this, and I tend to go way too long. So,
no worries. A lot of us were talking about that too, how to manage time, and it's either way too short, or we tend to go over, and then we wonder, what happened?
I'm certainly happy to answer any logistical questions that folks might have. But no, nothing else comes to mind for me.